Hello, and welcome to Chagpar MD. I'm Dr. Anise Chagpar. This week, I thought we would talk about low to middle income countries and prevention and screening for breast cancer. This is a topic that many of you have asked me about. Given the international audience of this channel, many of you have asked, what are the best ways to reduce the risk of breast cancer in populations that may be in low resource settings? So I thought we'd dig into the literature and provide you the very best evidence of how we can reduce incidence and mortality due to breast cancer all over the world. So what do you say? Let's get started. In the setting of low resource settings, we really need to address some unique challenges that these settings face. But when we look at the world, and here you see a map, everything shaded in pink, all of those countries have breast cancer as the most frequently diagnosed cancer in women in 2018. So that's a good part of the world who face this as one of their leading malignancies and certainly the number one cancer for women. And for those countries who don't have pink as their shade, their most likely cancer is cervical cancer, but breast cancer frequently is a strong number two. Now, when we dig into breast cancer in these low to middle income countries and we look around the world, we actually see that the majority of breast cancers, both in terms of incidence, that is to say, number of cases diagnosed, as well as mortality, really have a disproportionate number of cases being diagnosed in low to middle income countries, in Asia, in Africa. And in fact, if we look at cancer more generally, it is thought that given time, these countries will have a disproportionate number of cancers as non-communicable diseases like cancer overtake malaria, TB, and AIDS combined in terms of the number of cases diagnosed. And we will see the vast majority of mortality in these countries as well. But when we look at the proportion of incidence to mortality, we really see a disconnect between high-income countries and low to middle-income countries. This bar chart shows it well, I think. So if you think about countries like Australia, New Zealand, Western Europe, Northern Europe, North America, those countries near the top of this bar chart, what you can see is that they have a much higher incidence of breast cancer, but a lower mortality. When you look at the countries towards the bottom of this bar chart, so when we're talking about Southeast Asia, Western Africa, East Africa, Middle Africa, South Central Asia, the mortality rates are roughly about the same, but the incidence rate is much lower. And that means that as a proportion, the number of deaths per the number of cases diagnosed, it's actually much higher. This is also concerning when we think about trends over time. So when we look at this, the high-income countries, if we look at age-standardized incidence rates in the left-hand graph, those three countries in the top lines are the US, Italy, and Switzerland, high-income countries. What we see here is that not only do they have a higher incidence of breast cancer than the other countries, but that incidence has remained fairly flat. What we see in lower income countries, China, Japan, Korea, Thailand, is that they have a much lower incidence of breast cancer and that is increasing. If we look at mortality, we see, again, striking findings. So again, those top three lines are Switzerland, the US, and Italy, where we see that mortality rates are steadily declining. When we look at mortality rates in lower income countries, Japan, Korea, Thailand, China, those incidence rates are increasing over time. So if we ask ourselves, what are the differences between high-income countries and low to middle-income countries that can account for some of these differences, we see that there are a number of factors that may be at play. Now, certainly, there are risk factors, both non-modifiable and modifiable risk factors, that may be different between different populations. So when we think about non-modifiable risk factors, we think about things like genetics and endogenous estrogen exposure. How many children on average do people have? How early do they have their first pregnancy? When do they start having their periods? When do they go through menopause? These are things that we can't really change, but that may be different in different parts of the world. Then there are modifiable risk factors, things like obesity, exogenous estrogen exposure, that is through hormone replacement therapy. And when we think about these risk factors that may be different between high-income countries and low-income countries, we think about primary prevention. Primary prevention is where we actually can reduce risk factors and reduce the incidence or actually developing breast cancer to begin with. The other thing that's different, of course, is screening. And in high-income countries, we know that the vast majority of the population can avail themselves of screening through things like mammography. This is not widely available all over the world. And screening is a way of thinking about secondary prevention. Now, I'll mention here something that may be intuitive, which is to say that while we call it secondary prevention, getting a mammogram doesn't reduce your risk of developing breast cancer, but it does reduce your risk of dying from it. Why? Because secondary prevention really helps us to find these cancers earlier when they're the most treatable. And finally, mortality between high-income and low-income countries may be different simply on the basis of access to good treatment. So for the rest of this talk, I'm really going to focus on primary and secondary prevention. That is to say, how can we reduce the risk of actually developing the disease, and what are the best modalities for finding it early, particularly in low to middle income countries. Now, when we think about primary prevention strategies, there are a number. And while we have limited data on efficacy, these are some of the techniques that have been thought to be the most effective. So the first is to encourage breastfeeding. Why? Well, because number one, breastfeeding does impart immunological benefits to newborn babies. It is cost effective as a nutrition strategy. But the other thing that one should note is that the relative risk of developing invasive breast cancer decreases by about 4.3% for every 12 months of breastfeeding. The other is to encourage physical activity. We know that there's a risk reduction of 30 to 40% for women who engage in moderate to vigorous activity 3 or 4 hours a week. And this is something that we can encourage in all populations, not just low to middle income countries, but high income countries as well. And as we've talked about in this channel before, there are a number of other advantages to physical activity as well. The same goes for avoiding weight gain and encouraging ideal body weight. We know that overweight or obese women have about a 30 to 50% increased risk of developing postmenopausal breast cancer. So if we can reduce that, we certainly have done these women a significant favor, both in terms of their risk of breast cancer, as well as heart disease, diabetes, hypertension, and a whole myriad of other diseases. Now, what about dietary factors? There have been a number of studies that have looked at dietary factors such as fruits and vegetables, soy, meat, dairy, vitamins, and so on, with really no consistent findings. Where there have been consistent findings, however, have to do with alcohol. We know that alcohol increases the relative risk of breast cancer by about 7% for every 10 grams of alcohol consumed per day. So as much as or as few as 1 to 2 drinks per day can really increase your risk of developing breast cancer. What about exogenous estrogen exposure? Now, we know that hormone replacement therapy is associated with about a 35% increased risk of breast cancer for use more than 5 years compared to people who have never used exogenous hormone replacement therapy. And we have very good data as well from the Women's Health Initiative, where they found that conjugated estrogen plus progesterone was associated with a 24% increased risk of developing breast cancer at 5.2 years versus placebo. Now, you should note that unopposed estrogen, that is to say estrogen without progesterone, did not increase breast cancer risk, but overall, exogenous estrogen is thought to increase risk, and so as much as we can avoid that, the better. Well, what about secondary prevention or screening? When we think about screening for breast cancer, there are a number of screening techniques that come to mind. One of the cheapest is self-breast exam, but how effective is it really? Well, people have looked at this, particularly in low to middle income countries. There was a randomized control trial that took place in Shanghai with over 250,000 women who were randomized to either breast self-examination instruction or control. They were recruited 1989 to 1991 and followed through the year 2000. When they looked at the group who were trained in breast self-exam versus those who were not, they actually found that breast cancer deaths were the same in both groups, 0.10%. And the cumulative relative risk was close to 1, so no difference between the two groups. What they did find, however, was that in those who were trained to do breast self-exam, more benign breast lesions were diagnosed. So that really got people to question whether self-breast exam was really a good technique for early detection of breast cancer. There has now been a meta-analysis that was published by Hackshaw and colleagues in the British Journal of Cancer. Here I show you two graphs of observational studies where you can see that in these observational studies, those who were trained in or who practiced breast self-exam were less likely to die of breast cancer, less likely to be diagnosed with advanced breast cancer. But when you compare to people who found their breast cancer by chance alone, there was really no difference. And remember, all of these are observational data, and so there could also be confounding. So for example, in many of these studies, women who were practicing breast self-exam also had other characteristics that might have made them more likely to find cancer early. For example, they may have been younger, they may have been more affluent, and so on. When we look at randomized controlled trial data, there have been two large studies, one the Chinese study, as we previously mentioned, another in Russia, and both had similar findings. So in both studies, they found that women who were trained in breast self-exam were more likely to seek medical advice. They were also more likely to undergo a biopsy. However, the rates of diagnosing breast cancer and dying from breast cancer were the same as for control, which really again makes us question the efficacy of self-breast exam, even though it certainly would be very cost effective. Which brings us to clinical breast exam. Now, there was a randomized controlled trial that was done in India where they essentially trained community health workers to do clinical breast exam. They looked at 275 clusters of over 100,000 women who were aged 30 to 69, randomized these to either clinical breast exam or control. And they found over the 3 years of the study that more cancers were diagnosed in the intervention group versus the control group. And furthermore, the specificity was quite high, 94.3%. Now, the sensitivity was modest at 51.7%. The false positive rate was quite low at 5.7%, but the positive predictive value was only 1%. However, Of significance, particularly in low to middle income countries where so many patients are diagnosed with late stage disease, what this randomized control trial found was that there was a significant improvement in the stage of diagnosis. So they found that patients who were randomized to clinical breast exam were more likely to be diagnosed with early stage disease and less likely to be diagnosed with late stage disease. These findings have been replicated in other studies, such as one in Malaysia, for example, and numerous others. Now, it hasn't been a panacea. So this study, which occurred in the Philippines, again, looked at over 100,000 women aged 35 to 64 who were offered screening in 1996 and followed for the subsequent 3 years. Now, while they found that the majority of women accepted the screening, 92%, only about 2.5% were actually found to have a lump and were referred for diagnosis. Of those, only 35% actually completed their diagnostic follow-up. 42% refused further investigation, which meant that of those who actually did follow through, there were 34 malignant cancers that were detected, but 623 who had benign breast disease. So in this study, the authors really questioned whether clinical breast exam was efficacious in their setting. Certainly this has to do with the population involved. Are they really going to accept clinical breast exam? Will they follow through with diagnostic modalities? And certainly, as with self-breast exam, with clinical breast exam, we can find a lot of benign breast disease as well. But is it cost effective? So this was a modeling study that was done in Vietnam, where they looked at the incremental cost effectiveness ratio for clinical breast exam, using this between the ages of 40 and 55. And what they found was that this would equate to about $994 in US currency per life year saved. They did a number of sensitivity analyses, looking at participation rates, increasing the cost, increasing the screening interval, reducing specificity, and so on, and still found it to be highly cost effective. So we know that cost-effective strategies per the World Health Organization should be less than 3 times GDP per capita. In Vietnam, the GDP per capita is about 1,070 US dollars. So no matter which strategy they used, even with all of their sensitivity analyses, this came in well below 3 times their GDP per capita. When you looked at the work that's been done by Ben Anderson and colleagues at the Breast Global Health Initiative, when you think about those countries who have a basic level of resources, they actually do prefer clinical history and clinical breast exam as the primary modality for detection for these cancers. Mammography is really only added as a routine technique for those countries who have enhanced or maximal resources. So why is that? Well, there are a number of factors to consider, and I call these the 5 Ps. So the first is the population. What is the epidemiology of breast cancer in your particular low resource setting? Many low resource settings find that breast cancers are found very early at a young age, when mammography may not be as efficacious because breast tissue tends to be more dense in these populations. Second, what is the life expectancy of these populations? Where life expectancy is shorter, there may be fewer number of years where mammography can be really effective. What are the cultural beliefs? If we find breast cancer early, is this something that the population would embrace? Or would they shun this for more natural techniques and alternative modalities? And are there other factors, such as adherence to mammography and all of the follow-up that's required? The next P is personnel and equipment. So for many low resource settings, there simply isn't a highly qualified medical team. And you really need that in order to have a high quality mammography screening program. And then think about the fact that even if you did have mammography, what are all of the downstream steps that are required? If you find something on mammogram that is not palpable, do you have the stereotactic core biopsy equipment and the personnel to operate this in order to be able to diagnose what you see? Do you have the ability for needle localization for breast conserving surgery? Do you have the ability for adjuvant radiation therapy? Which brings me to the next P, which is placement. Where are these resources, if we have them, to be located in terms of geography and access? For many low to middle income countries, much of the population is rural, and access to main medical centers can be difficult. What about P for payment? What is not only the cost to society of having the actual equipment and personnel, but the cost to the patient? Can people afford screening? And can they afford the diagnosis and treatment that ensues? And finally, there's the P of pitfalls, which many of us in the Western world have also found. Whether this be for overdiagnosis, pain, anxiety, radiation exposure, etc., mammography is not without its faults. And so all of these factors really need to be taken into consideration before you implement a screening program with mammography in a low to middle income country setting. We know that when we look at randomized controlled trials, there are a wealth of data that mammography does in fact save lives. This, however, seems to be the most efficacious for patients between the ages of 50 and 69 with a biennial screening strategy. If we look at these data, in the population who are aged 40 to 49 and in those who are aged 70 to 74, you can see that the breast cancer mortality relative risk crosses 1, which is to say that there really doesn't seem to be a statistically significant reduction in risk in the trials that have looked at patients in these populations. Which brings me to this. Even in high-income countries such as the United States, the professional society recommendations for breast cancer prevention and screening are all over the map. So in terms of when should screening start, what should the interval be, what should be the concluding age, all of these societies vary. And so we really need to take this into consideration, especially when we're thinking about using a technique which may be pretty expensive in low to middle income countries as to how we implement this. So what does the World Health Organization say? They really have recommended mammography only be considered for women ages 50 to 69. In fact, they have come out against mammography in patients under the age of 50 and over the age of 70 in low resource settings. In addition, even for women who are between the ages of 50 and 69, they've really broken it down into limited resource settings with weak health systems and those with relatively strong health systems. In the former, who have weak health systems, where the majority of women with breast cancer are diagnosed in late stages and mammography screening is not cost-effective and feasible, early diagnosis of breast cancer through universal access of women with symptomatic lesions to prompt an effective diagnosis and treatment should be high on the public health agenda. They're really focusing here on clinical breast exam, a low-cost screening method, as a promising approach in these settings. In those who have relatively strong health systems, you could consider organized population-based mammography screening programs only if the conditions for implementing such a program are met and if it can be implemented so that women's decisions are consistent with their values and preferences. Well, what did the WHO mean in terms of if the conditions for implementing such a program are met? Well, they had a variety of criteria. And these criteria, as you can imagine, are pretty difficult for many low to middle income countries to meet. So for the first is that they need to have robust data, including pilot studies demonstrating feasibility, cost effectiveness, and affordability. There needs to be coordination of all activities by an autonomous management team responsible for service delivery, quality assurance, and evaluation. They have to have a well-developed, equitable health system with cancer control planning integrated into their national NCD prevention and control strategy. They have to have validated protocols for all steps of the screening process, including diagnosis, treatment, and palliative care. They have to have demonstrated adherence to comprehensive evidence-based guidelines for quality assurance, both on the professional side as well as on the technical side. And they have to have quality assurance and information systems that will allow for recall of patients, follow-up, monitoring, and they have to have regular monitoring, evaluation, and reporting of program performance, including both process and outcome measures, as well as women's safety and satisfaction. They have to have sufficient organizational and financial resources to sustain all of these program components, including the equipment, infrastructure, and workforce, including the capacity for training, reporting, and knowledge exchange. Now, that's a pretty tall order for most low to middle income countries. This was an analysis by Li and Xiao that was published several years ago that really looked at screening mammography in the world. And you can see that the areas shaded in light blue are those that have actually implemented screening mammography, or at least have taken the steps towards that. But interestingly, even in these countries, adherence rates vary considerably. And all of these countries demonstrate adherence rates well below 70%, a level that's considered necessary to confer a reduction in breast cancer mortality by the WHO. So I think that before we embark upon screening mammography in these low to middle income countries, we really need to take a step back and think about whether we're ready to embark upon this, whether we have all of these resources. If not, considerable downstaging can be met with things like clinical breast exam and better patient education. On top of which, we can't forget all of the things that we can do in terms of educating our population about primary prevention strategies. So in summary, breast cancer is still the most common malignancy affecting women. Screening and prevention may need to be individualized in different countries because for all of these countries, there are biological, cultural, social, and economic differences that really underpin what is going to be optimal for their populations. This is not necessarily a one-size-fits-all problem. I hope that you all found this video helpful. For those of you who are in low to middle income countries and who are trying to raise awareness to reduce breast cancer incidence and mortality where you live, please do leave me a comment in the description box below. Let me know what you're trying, how it's worked for you, and what we can do to help further your efforts. Please like, share, and subscribe. I'd love to know what you thought of this video, and I hope that your endeavors will be successful. Until next week, this is Dr. Anise Chagpar wishing you all a safe and healthy week.